And welcome to the Research Works podcast, brought to you in association with Curtin University and the Healthy Strides Foundation. Your hosts are Dr. Dana Poole and Dr. Ashley Thornton, and together we will interview world-leading researchers in the area of child health to support your practice in being more evidence-based.
Today we have a wonderful paper to discuss and share with you all. It's a paper that helps us to really look into the future a bit and consider the important things that we do during childhood that can influence outcomes when children become adults.
Yeah, this is such an important area. Even though I'm a pediatric physiotherapist, parents of children with cerebral palsy are often requesting more prognostic information about functioning. And there's been an increase, lately there's been limited publications, but we have been increasing in that area very much recently. And this is why this paper is so important. Now, this paper was published in 2021 in Developmental Medicine and Child Neurology, and it's titled Changes in Walking Ability, Intellectual Disability and Epilepsy in Adults with Cerebral Palsy Over 50 Years. It's a population-based follow-up study, and this is just so important.
And to talk us through this paper, we're so fortunate to have the lead author, Dr. Ulrica Jonsson, joining us on the podcast today. Welcome, Ulrica.
Welcome.
Hello, and thanks for having me.
Thank you for joining us. We're really excited to talk with you today. And just to give you a little bit of background about Ulrica, she's a rehabilitation consultant at the University of Gothenburg in Sweden. Her main clinical load is in adults with childhood onset disabilities. And there's been a real dearth of publications, treatments and recommendations for adults, particularly with cerebral palsy. And this is what spurred her on to contribute to the body of knowledge in this area.
I absolutely love it when research comes out of the clinical space, when clinicians start looking for answers, they can't find enough on it, and that is really what spurs them on to go and find out more information. So that sort of combination is something that really intrigues me, and I'm sure a lot of our listeners will feel the same way as well. So I'm really looking forward to this conversation, but I think we need to know a little bit more about Ulrica.
We like to start our podcast with a little bit of an icebreaker. And the question we thought we'd ask you today is what your favourite thing to do out of biking, hiking or walking is and why?
I absolutely love biking. So I bike to work every day and I bike in the forest and I like biking, all kinds of biking.
Oh, that sounds so good. I like how you said biking in the forest as well. That's just something that we don't really get to do very much here without, I guess, dangerous animals coming to us. I constantly think that I'm going to, run into some snakes somewhere. So I'm a little bit scared of our forest. Ash, what would be your favourite?
Oh, whenever I go somewhere new, I absolutely love to walk around the city or town or wherever I am, just to get my bearings and figure out obviously where all the good coffee places are. But there's also something about hiking and being immersed in nature that I really love as well. So if I had to choose one, I think I'd go with hiking.
Yeah, there's something really nice about the whole nature aspect to it when there's no dangerous animals coming at you. If you've ever seen National Geographic on all the things that happen in Australia, I'm clearly not really an outdoorsy person just based on that. So I would definitely say walking for me because I love this. I love walking around cities and discovering cities, and I just love seeing what's around when you're just going at a slower pace. I think there's something really lovely about it. But I'm going to live through Ulrica and live through the fact that maybe one day I could be a biker that could go through the forest. So maybe one day. I think you've inspired me. Well, now that we know some very crucial information about our lead author, let's get into the main aspects of this paper itself. So we're going to go through the PICO format for this. The population here it's a population-based study from the Cerebral Palsy Register of Western Sweden. And this involved 142 adults with cerebral palsy born from 1959 to 1978. So this includes 82 males and 60 females with a mean age of 48 years and 4 months and a range of 37 to 58 years. Now, of these participants, 44% were classified as having unilateral spasticity, 35% as bilateral, 17% as dyskinetic, and 4% as ataxic. Now, to determine if walking ability and the presence of intellectual disability and epilepsy change from childhood to 50 years of age, and if these changes were related to age, sex, or CP subtype, a series of questionnaires and interviews were carried out. This was then compared to childhood data, which was collected when the person was between 8 and 4 years of age. Now for the outcomes. This study reports that walking ability does significantly change, where the proportion of adults walking without aids had decreased from 71% to 62%, and that wheelchair ambulation increased from 18% to 25%. Changes in walking ability was related to cerebral palsy subtype, but not related to age, sex, pain, fatigue, or body mass index. The proportion of individuals with epilepsy changed from 9% to 18%, but those with childhood epilepsy, 46% became seizure-free without medication by adulthood.
Some really interesting results there, Ulrica, and I'm really looking forward to talking through all of that with you in more detail. But before we get into the specifics of the paper, we have spoken about the Western Sweden CP register before when we spoke with Dr. Magnus Pohlman on his paper about autism, ADHD and intellectual disability in individuals with CP. And we learnt during that episode that this register is one of the oldest in the world, which is so valuable when we want to look at longer term follow-ups. I was wondering if you could tell us a little bit more about the register and the data that is actually tracked over that long period of time.
Yeah, so the register was started in the 1950s and is still running. And it includes all children who are born in this area of Sweden and who are diagnosed with CP. The data is entered in the register at one time in childhood, and there is no follow-up entered into the register. And then every 4 years, there's been a paper published describing the latest birth cohort and the changes in the prevalences of CP and the causes of CP over the years. The register has evolved over time, and today it includes many more variables than it did in the beginning. So there's more now about associated impairments, causal factors, and MRI findings. But a major strength of the register is that it includes all children with CP, and it's population-based. So it makes it possible to do population-based studies on both children and adults. So the register itself may not contain all the data that you're interested in, but you can use the register to find these people to do a population-based study. And you can also use it to see if the population you are studying is representative of the whole population or not.
Wow, that's really interesting when you consider how much data is actually available through such a register. And it's really interesting now that we've been able to look at these outcomes in who are now adults, in people who are now adults. So I thought now that we know a little bit more about the register and what kind of data has arrived from that, I just want to talk a little bit about this actual space itself in terms of, what's already been published. This has been so interesting because I'm constantly thinking about what it is that we do now that can have an impact into the life course, because you can't think about a young person without thinking that they're going to get older and become an adult. And the literature has always been really sparse in this area, particularly around adults with cerebral palsy. So as a physician working in this area currently, can you tell us a bit about what we currently know about adults with cerebral palsy and their unique challenges?
Well, I could talk all week about this, but I'll try to be brief. So I guess what I want to say is that adults are different from children. Their life situations are different and their bodies are different. And the other health conditions that they encounter are different. And then the healthcare system is different as well. So the staff at the pediatric hospital, they're used to treating patients who can't speak for themselves or who need all kinds of adaptations to be able to undergo investigations. While at the adult hospital, everyone is supposed to follow standard procedure and no exceptions made. And if you can't comply, you're out. And I may be exaggerating a little bit, but you get my point. It's difficult. And the staff is not used to people with childhood onset disabilities. They are such a small minority in adult healthcare. So that makes it difficult as well.
So when it comes to, we're talking about navigating through the health system, which is a very different experience. What are some of the common things that you might, as a physician, be treating or supporting someone as an adult with cerebral palsy?
The adults that I see in my clinic are usually adults with severe cerebral palsy, and they often have intellectual disabilities or autism as well. And on top of this, they have difficulty swallowing. They may be underweight. They have gastroesophageal reflux.
Yeah.
And they have problems with swallowing and aspiration pneumonias.
Right.
And they also have often problems sitting in a wheelchair, or problems being positioned sitting or lying down.
Yeah, sure.
And they have pain.
Yeah.
And all this combined.
So what about, you spoke about pain. What can be done, and is it really as frequent as we've been reading? We've tried to understand more and more about pain in cerebral palsy. What sort of areas do you notice that the pain tends to be in the body, and how can it be treated?
This is a difficult area, I think.
Yeah.
Because I find that pain is very common in adults with cerebral palsy.
Yeah.
And it can be musculoskeletal pain, but it can also be pain from the stomach,
right,
or pain from the bladder, or pain from sitting, or pain that you just don't know where it comes from.
Mm-hmm.
And the patient may not be able to say where it comes from.
Sure.
Or may not just be able to express that they're not feeling well.
Yeah.
And you don't know what is causing this. And it's difficult to treat it, because you just have to try.
Yeah.
And maybe it's constipation. We'll try to treat that.
Yeah.
Or maybe that wasn't the problem. Maybe it's the wheelchair. We need to adjust the sitting position. Or maybe it's instead it's something completely different. So it's a lot of trial and error, actually.
Yeah. I was just going to ask a question about comorbidities in adulthood and the things that we would commonly see as people start to age, like cardiovascular disease, diabetes, and things like that. Is that something that you have to deal with regularly in this cohort of people? And is it more difficult to treat things like that?
That is something that I don't know that much about, because at this clinic, I don't see that type of patient usually. And I was going to say that is one of the most surprising things for me in doing this study, that I got to meet all these adults with CP who are so high functioning, that have an employment, they have partners, they have children, and I don't usually see them in my clinic. So my view of adults with CP is very biased, I'd say. And since most of my patients are younger, they are maybe between 18 and 25 or 30 and severely affected. It's completely different from the adults that are 50 years old with minor walking disability and trying to get on with a normal life and meeting all those expectations. So I think they have their cardiovascular health and diabetes and those things taken care of by their GP, and I don't see it here.
Ulrica, can you talk us through the measures that were used to measure the current status of these adult participants in your study and the results that you found around those measures?
We assessed walking ability in adulthood, and when the register started, the GMFCS classification was not invented yet, so they had classified participants into 3 levels: walking without aids, walking with aids, or using wheelchair ambulation. So in order to be able to compare with that, we did the same thing. And then we looked for intellectual disability, and that was defined as having an IQ below 70 and deficits in adaptive function. But then all patients had not been tested. And in Sweden, all individuals who have an intellectual disability are offered a place in a special school or special employment and special housing. And this is all for free. So it's very uncommon that people would opt out of all of these services if they have an intellectual disability. So we use that as a sort of proxy to find all participants with an intellectual disability in adulthood. And then we asked them about epilepsy and if they had seizures and if they had medication. We used a fatigue severity scale to evaluate fatigue. And we asked them about pain, measured body weight and body height, and calculated the BMI from there.
And were the results what you were expecting? Was there anything that surprised you that came out of this paper?
I guess what surprised me the most was that I met all these adults with much higher function than I was used to meeting at the clinic. And it was obvious to me that my view of adults with CP was very biased. So that was interesting to me. And then the fact that there was only 19% that showed a decline in walking ability, that was surprising. I think that there are many who experience a decline in walking ability, but that the decline is not big enough to make them start using walking aids or wheelchairs.
Yeah, I thought that was quite an interesting factor because the percentage was definitely less. There's an article that I'm quite familiar with. I think a lot of people have read the Opheim article published in 2009 regarding walking function, pain and fatigue, and it was over 7 years. And they reported like a decline in walking ability in up to like 52% of individuals. So I guess, what are your thoughts? And how does your study relate to that, even though there's that difference in the rate that you found?
Yeah, I think that, their study was also population-based,
yes.
So that's the same. But then I think the most important reason for the difference compared to our study is that in our study, the GMFCS levels 1 and 2 were combined into one level that was labeled walking without aids.
Yeah.
So a shift between GMFCS level 1 and 2 would go unnoticed in our paper. And that was also the most common deterioration in their article, a shift from GMFCS level 1 to 2. So that makes sense in a way.
Yeah.
There wasn't that many in their article that started using a walking aids or wheelchair.
That's right.
Either.
Yeah.
And then their study showed less deterioration in unilateral CP, and that was the same in our study population.
Yeah. So I guess, when you start looking at it in that perspective, it's quite interesting. There is a bit more similarity than you might think, even though those numbers seem quite large. And that if you are treating someone who's GMFCS level 1 and 2, it's really important to keep in mind what that might look like, because deterioration in walking ability might be something that you should consider. And it's we've got now, both papers that will be suggesting that, and it's really important to note that. Is there any reason why you think there's that shift between levels 1 and levels 2? Do you have any thoughts around that?
I remember that Opheim's article also showed that many participants shifted from 2 to 1.
Yeah.
And in my experience, it can be a little difficult to choose what is the correct classification.
Yep.
Is it 1 or is it 2?
Yep.
So I don't know.
Yeah.
Maybe small changes, and maybe it comes and goes a little bit, depending on how you feel today or this week or this month.
Yeah.
Also.
Yep. I think that's really valuable to talk about because, we're not static as people, as a functioning adult in the community. There are some days I might do things a different way than others, and it might be dependent on how I'm feeling. It might be dependent on the weather. There's so many different things we need to consider. And though we have these classification tools that help us, one, we need to remember that they're not really widely used in adults, and the definitions can be quite different, and that's still something that's evolving. But the second part of it is, we just really got to think about people as individuals, and minor changes that might not come up in a classification might still be really important. The difference between 5, 10, 15, 20 meters can make all the difference in someone's functioning.
Exactly. Exactly. And they talk about feeling stiffer or having less balance or not being able to walk as far as they did before, or having more pain. But still, that doesn't change the classification a lot of times.
Yeah.
So
and they have the strategies at that point in time to deal with those, whatever it is they feel at that point in time.
Mm-hmm.
And I suppose when you think about classifications sort of came about to help us to communicate with each other, to understand, on a larger scale, on a high level, what treatments and assessments might come into play. But I think your paper, Ulrica, just really highlights how we just can't put people into these classifications and go, they're classified as this, therefore we'd expect that. It is so individual, and this is where personalized, medicine becomes really important, doesn't it?
Mm-hmm.
Ulrica, one of the things that's unique about your results is that you report both declines in walking ability and improvements in walking ability. Could you talk us through this result?
Yeah, sure. Just to say that Oppheim's article also showed improvements in walking ability in some of their participants. In our study, there were 4 participants who had improved, and I think some may just have been late in developing their walking ability, and some may have needed corrective surgery. I think there may have been others who improved after 4 years of age as well, and then maybe declined again in early adulthood. So we don't have any data on the participants' best ever walking ability. We only have early childhood and then 50 years later.
And I know that for the goal of functional walking, that's so important during childhood, and often a lot of intervention in childhood aims to actually improve functional walking for children with CP. So for those that then lose their walking ability, what do you think that means for them?
I think this is a really difficult question, actually. How much focus should you devote to walking when growing up? And what if it turns out you can't keep it up? Because it's not always easy to start using a wheelchair in adulthood. I think psychologically you may feel as if you fail if your most important goal growing up was to be a person who walks, and that's your identity.
Yeah.
And now as an adult, maybe you have made a life for yourself that requires walking.
Yeah.
Also, maybe if you work at an office that's inaccessible with a wheelchair, you'd lose your job.
Wow. Yep.
Or you live in a house outside the city where you need to be able to walk to the bus and board the bus on foot. And if you can't do that, you're stuck in your house. So it's difficult. And I don't know what to do about it. But I think at least it's a good thing that both patients and parents know this when growing up. To be aware that they might lose their walking ability in adulthood. And especially what we've seen is that it's more common among those who have dyskinetic CP. So maybe be more aware of that, while people with unilateral CP often are able to keep walking.
Yeah, that's a really interesting. Oh, those are all such interesting points, actually, Ulrica. I've got my brain is just like buzzing along now. Interesting point about people who have more dyskinesias that tend to lose the ability to walk. I know that in earlier data that's been shown, I think it was quite a long time ago, 1995. A group, Murphy was the article, and they were also noted the same thing. And the reason that they attributed for dyskinesia is often you would use your upper limbs to stabilize and hold onto a walker, but because a lot of movements do happen, your shoulder joint can become it's actually quite painful. So if you can't use your upper limbs to help to weight bear and to use a walker, you suddenly don't have much option but tend to go into a wheelchair because of pain that's associated with that. And I've certainly seen that happen over time because, we often think about walking, its legs, but using a walker does require upper limb control and being able to hold on to something. And if you don't have that, your only option is to go into a wheelchair. Have you seen much of that in your practice at all? Or what do you think about that?
Yeah, I think you're right. I don't have much more to say about that.
I love you. And the other, you can tell I'm very passionate about this because it's something that I think we all need to think about. So even in hemiplegia, which is often you saw the unilateral spasticity, it tends to be very pain related because of the compensatory movements that tend to happen. So you can push on to a degree, you keep pushing on. So you tend to see walking ability decline much older. It's probably the group that, in 40s and 50s because of all that compensatory movements that happen and that's pain. And it might be just a difference of a few meters, but it can make all the difference in the world of a person. So on that, in terms of the function that might have, I'm really interested in what your thoughts are. And Ash, I know with your background as well, in terms of, what could we do about it, is if you have this decline in walking and your identity growing up was, to be able to walk, you work so hard toward it, what can we do now as clinicians? You talked a little bit about we need to talk about it. What kind of things could we sort of be bringing up in conversations now?
I was also really curious about that, Dana, and whether, Ulrica, you had any thoughts on this. You know, we do need to make sure that, I suppose, there's an equal emphasis on a lot of the other goals a child might have early on in that period of development, to focus on things other than walking, with the understanding that that may or may not be something they can continue on with throughout their life. I was just wondering what you thought about that.
Yeah, I think that is very important to realize that walking is not everything. There are so many other things that an adult has to handle in everyday life. And walking is just one part. And I understand that being able to walk, that gives you a unique freedom, and it's worth it. If you can walk for 10 years or 15 years, I'm sure it's worth it. So I really don't know how to handle this problem. It's worth it, but it's not. I guess you need to know that it's not just practicing and training and getting to the threshold of walking.
Yeah,
that's not enough. You need to pass the threshold for a while and be able to walk without using all your focus or concentration or effort on walking for it to be feasible in adulthood.
Yeah.
But you won't know that until you've tried.
Yeah, that's right. That's right. And I think when you say that, I think of how, you know, if you need to suddenly change to a wheelchair as an adult and you haven't had much time to practice or learn how to do that, you know, without it becoming an absolute necessity, suddenly you've got this new skill that you have to learn with the pressures of being an adult, and you've got this wheelchair, you have to use it, otherwise you can't function. It just becomes something that's too much. So, you know, identifying that early and introducing a breadth and a variety of different mobility devices as you're growing up will give you that opportunity to perhaps be exposed to that and be able to choose which device you might use in different circumstances. And that in itself might help to preserve functional walking for where you need it and when you might need it. Yeah, I love this area.
That's a really good point.
I love talking about it, clearly. So moving away from walking, which is a little bit tricky for me to do because I love talking about it, and Ulrica, like, you know, I'll probably keep talking to you about it after the podcast as well. What I found was really interesting is that you also looked at some other domains like intellectual disability and epilepsy. So can I talk about the epilepsy result first up? So what you had noted there, it was just another outcome. And it was really interesting here that almost half of the participants with epilepsy in childhood had discontinued their medication and were seizure-free. So, you know, what does this mean, and how do you explain this result?
Well, to me, this is proof that epilepsy doesn't have to be lifelong in CP, and that if a patient is seizure-free on medication, it could be worth the risk to try to taper that medication, provided that is what the patient wants to do. Medications can have side effects, and we met patients who had been seizure-free on medication for 10 years or 20 years and still took their medication. And I think a lot of times in our healthcare system, adults with CP and epilepsy are not followed up by neurologists. They get their new prescriptions by their GP once a year, and nobody asks them about their epilepsy. It just keeps going. And I've also seen a couple who have tried to contact a neurologist to at least have a second opinion about can I taper my medication, and the answer they get is that, well, we don't think it's worth the risk because you do have CP, it's an organic brain injury, there's a higher risk for relapse and new seizures. And while there is a bigger risk for those who have an organic brain injury, it's not 100% risk. So I think it's sad, actually, that if people keep taking their anti-epileptic medication for 30 or 40 years without needing to.
That's such a good point. And again, it's just not putting people in the same, like not treating people as if they're static and that you do change, and, you know, reviewing is so important. And, you know, as we would expect ourselves to change over time, health needs will change over time for a person that has cerebral palsy as well.
So, Ulrica, one of the other outcomes was intellectual disability. And the data that you had presented suggests that the presence of intellectual disability had increased compared to data that was collected in childhood. So what do you think would have contributed to this, and how might you explain this result?
Well, I think the main reason is that in early childhood, a mild intellectual disability is not always apparent.
Sure. Yeah.
You'd notice it later on.
Yeah. Yeah. And so I suppose that might just highlight, again, the fact that, reevaluating this may be of good importance to ensure that someone has adequate supports later on in life.
Yeah, absolutely.
Yeah. So already we've talked about walking ability and the changes and implications of that, and the need to not look at someone in a static way. We've talked about epilepsy and intellectual disability now. So what are your thoughts? So based on the results of the study, what would be your advice for clinicians who are currently working in, well, first of all, child health? What sort of advice would you give to those clinicians?
To clinicians in child health care, I think maybe to be aware that walking ability may decline in adulthood, especially for individuals with dyskinetic CP.
Yeah, sure. And that's probably a really good conversation to have with families and to identify that early. So, okay, what will be your main advice for clinicians working in adult health?
Just to keep seeing adults with CP regularly, and to take a closer look at their epilepsy. Ask them if they still have seizures, and also to retest cognitive functioning if there are any signs of problems in this area.
Yeah, that's really, really good advice as well.
I guess that kind of in a way leads us to the next part, which is where we sort of ask you, what do you think, what are your recommendations for future work in this area, and where do things go from here now?
What I'm really hoping for is that people will start doing interventional studies in adults with CP.
Okay.
Actually, about almost any of the health problems that are common in adults with CP. So I would like to know, what is the best way to treat gastroesophageal reflux and vomiting, for example?
Sure.
Or choking on saliva, or phlegm in the airways, or should we recommend more physical activity for cardiovascular health and to preserve muscle mass?
Right.
Or should we recommend less physical activity to prevent overuse and pain and fatigue?
Yep.
Or more specifically, which activities should increase or which should be avoided, and in who?
Yep.
So there's so much we don't know. There's so little evidence to guide us. So just bring it on.
There's a lot of questions. I think it's great. This is a call to action for all the clinicians out there who are interested in this area. There's clearly a massive need. But the most important thing is we've identified the need, and that's what this paper really does highlight. It's a great foundation now for what's coming for the future. All right, now we are going to our final segment. Thank you so much, Ulrica, for that. We've got one last thing to ask of you, where we now have the Tell It to Ed segment. Now, this is the 60-second pitch to the Everyday Man Ed. Now, for all of those who are not so aware, Ed is our producer, and he doesn't have a background in child health or research, but he has been listening in on every single conversation. So this is a great opportunity to practice our pitch to someone who might not have a background in child health. So, Ulrica, take it away.
So we followed up 142 adults with CP in their 40s and 50s to see if their impairments had changed. And we found that out of the 117 who could walk as children, 9 had started using walking aids and 13 had started using wheelchairs. And in childhood, 23 participants had a diagnosis of intellectual disability. And in adulthood, 10 more cases of intellectual disability had been identified. We also found that out of the 13 participants who had epilepsy in childhood, 6 of them no longer had epilepsy in adulthood. So our conclusion is that from childhood to middle age, walking ability can decline, and intellectual disability may become more apparent, and epilepsy in CP is not necessarily lifelong.
That is the perfect summary.
Wow.
That's a perfect summary. Thank you so very, very much. Now, Ed, do you have any questions?
As usual, I have lots of questions, but I'm always reminded that I only have time for one. But Ulrica, I'm very impressed with, obviously, English is not your native language. I'm always impressed by incredibly intelligent people who can verbalize all of their expertise and knowledge in multiple languages. So it's very impressive.
It is amazing.
Now, obviously, I don't have a background in health of any sort. I kind of dabble in IT and marketing for the most part for my job. So my understanding of health has been through what I've learnt through the podcast. So we're now 19, 20 episodes in. And I think I've managed to piece together little bits of information that hopefully makes me sound intelligent to some people who know what they're talking about. But I guess my question is with children and then adults, obviously children move to become adults. But one of the stats that Dana and Ash have told me about is that therapies and research takes 15, 17 years for it to come to fruition. So I guess for it to be out in the community or be something that people can take advantage of. So obviously you've had your results. Do you think with today's technology, with the methods that are available today, and if there is a way to shorten and compress those 17 years into something that's a lot more effective in like 2 to 5 years, would that make a significant difference compared to what you've seen from children moving to adults? Sorry, that's a really long question.
I hope that it's not going to take that long anymore.
Okay.
I mean, 15 years ago, there was almost nothing to be read about adults with CP. And I can remember starting my career as a physician without the internet and having to find information by looking for colleagues who might know something.
Wow.
Or
Yes.
going to the library and start looking at old textbooks that never had the information you were looking at or looking for. So it has to be quicker now. It just has to be, because you can just open your computer and look and Google what's the best treatment. So I think
Sure.
that will automatically make it quicker. But then, of course, the big organizations like the big hospitals and the state and what the state pays for and what treatments are considered worthwhile, that's going to take a long time. It's still going to take a long time. Everybody's going to have to agree on those things. So while I have a little hope, I don't think it's going to be quick.
Okay.
Unfortunately.
Well, I still feel your optimism, and I feel like anything that's published in this area, clinicians will see really quickly and go, we need to read this and lap it up straight away. So interesting question there, Ed. You definitely are learning, which is great.
Thank you.
And thank you for answering that question, Ulrica. Really appreciate that. So really, for everyone else who wants to know a little bit more about this or have a look at the article itself, really encourage you to read it. So head over to our website, researchworks.net, and we'll have some links to that so you can actually have a read of it yourself as well. And remember, if you want this recorded as part of your CPD requirements, the form you can fill up on our website so we can help you to keep a record of that as well. But for now, we say thank you so much, Ulrica, for joining us on this podcast this week. Thank you.
Thank you so much, Ulrica. We really enjoyed talking to you today.
Oh, thank you so much. It's been so much fun.
Oh, good. I've had such a good time having a chat with you. Thank you to everyone, and goodbye.
Bye.
Bye.